Hello friends, welcome to my today's session on local anesthesia video part 2. I have already covered the basic introduction of local anesthesia method, history and the pharmacology of different drugs of the local anesthesia in my part 1 lecture. Those who are not yet attended that lecture, please go and attend that. Then proceed for the today's part 2 session. Okay. Today I will be covering a regional anesthesia technique, its method, the mandibular nerve block technique and their procedures with landmark. So let us start. I am a Dr. Hemant Bhavnerkar. I am a Mumbai based oral and maxillofacial surgeon. Let us know what is the regional anesthesia first. As a synonyms, it's also called as a local anesthesia or a regional anesthesia. It's a most widely used method in a dentistry. Without local anesthesia, we cannot think about the painless dental procedure. Right. So, what is a local anesthesia method? Basically, a local anesthesia is a for is part. It's divided into two main parts. One is a maxillary nerve blocks, maxillary anesthesia technique, and second is a mandibular nerve block or the mandibular local anesthesia technique. Right. LA, as we know that LA must come in contact with the 8 to 10 of the nerve length. So then only it will act as a nerve block. Otherwise, our nerve block will not work properly. And as an anatomy, we already learned that we have to go as near as possible to the main branch of the nerve. So that point we deposit our local anesthesia solution and will get a desired result of the local anesthesia with the different principles of mechanism, which I have already covered in my previous session. Right. The various types of the anesthesia procedure. The main types is a nerve block technique, a field block technique, a local infiltration technique, intraligamentary technique, topical anesthesia technique or topical application, and the intraosseous anesthesia technique. For the dental extraction and the oral surgical procedure, mostly we use a nerve block technique. Then local infiltration we use for the soft tissue procedures or the periodontal or the periodontitis procedure. Intraligamentary technique or the intraligamentary nerve anesthesia also we use for the combination of the extraction of the dental tooth when the cases of chronic infection. Topical anesthesia we use before the injection of the local anesthesia. Intraosseous anesthesia technique we use for the osteomyelitis and the bone marrow infection and the bone marrow carcinomas. A field block technique is a more wider technique in that we have to block the particular area of the nerve block. It may contains multiple nerve block technique at a time. Right. So for the dental anesthesia, we are going to see a main mandibular nerve block technique in my today's session. As a technique of injection, as we know, we always use a sharp needle and beveled needle. We mostly use a 26 and 27 gauge of needle of 1.5 inch long needle. Right, before injecting the local anesthesia, we wipe that tissue and dry that oral mucous membrane and then apply a topical lignocaine gel to numb that area so patient will not feel the injection prick also. After that we will wait for the 2 to 3 minutes, then we inject the anesthesia solution in the region where the temperature is very cold, below sub-zero temperature, a minus degree Celsius temperature. At that time we have to warm the local anesthesia solutions also. As we know that injection in the cases where the patient is having a first time local anesthesia technique, we have to do a sensitivity test also or the patch test also on the skin over the hand. Then only we have to proceed for the local anesthesia. Right. Let us start with the mandibular anesthesia methods. Right. Before we start the mandibular anesthesia method, we should know the anatomy of the pterygomandibular space and the mandibular nerve anatomy. Right. As we know, we have to deposit our local anesthesia solution in the mandibular space, pterygomandibular space, so the our nerve is mostly passed through in that region, and it goes to the mandible bone from the mandibular foramen. So we have to go to the close. As we know, the local anesthesia nerve block technique is an anatomically driven method, so we have to be very thorough, and we should have a deep knowledge of the exact anatomy of the inferior alveolar nerve and the pterygomandibular space. Right. As we know, the anteriorly we always have a pterygomandibular raphe and fiber of the superior constrictor and the buccinator muscle that are inserted into it. Then posteriorly we have a parotid gland. Then lateral wall, we have a inner surface or the medial surface of the ascending ramus of the mandible. At this point we have to reach just above the mandibular foramen to deposit the local anesthesia, so our local anesthesia will work exactly and very nicely. At the floor of the floor of the its we have a medial pterygoid muscle, and at the roof a lateral pterygoid muscle. Right. Here we can able to see the same anatomical landmark. Here the anteriorly pterygomandibular raphe, so we have to always inject just at the midpoint of the pterygomandibular raphe or just above it. We have to insert our needle from the opposite side at the premolar region, and we have to reach as near as the inferior alveolar nerve. Right. And it's just medial to the anterior border of the ramus or the ascending ramus, so we have our needle will be there. Posteriorly we have a parotid gland, medially a medial pterygoid muscle, and the laterally we have the masseter muscle. Right. So this anatomic we should know thoroughly before learning a mandibular nerve block. Here the three main branch also we have to look. As we know, a mandibular nerve block consists of the involvement of the main inferior alveolar nerve block, a lingual nerve block, and a long buccal or the buccal nerve block. So with this all the blocking of this all three nerve will achieve a good anesthesia for the that region to do the procedure. Right. Here we have to give attention that the main branch of the inferior alveolar nerve goes inside the mandible body of the mandible from the mandibular foramen. Right. So this landmark we have to keep in mind. So we have to deposit the local anesthesia solution at this level. So this anatomy we have to keep in mind. For the mental nerve block we have to inject at this region, and for lingual nerve block we have to inject at this region, and for the long buccal we have to inject this region. Right. Just on this image I am telling you grossly. We will see the exact procedure in my next slides. Let us start. Intraoral technique. So classical inferior alveolar nerve block technique is given by the different authors, but the main method we use is given by Clark and Holmes in 1959. Then the modifications are given in the open and the closed mouth technique given by Vazirani, akinos, and the Glasgow techniques are also there. Then anterior ramus technique and the Angelo Sergetti method is also there. We are going to see the different classical mandibular nerve block technique in my subsequent slides. Then it, as I said earlier, with the inferior alveolar nerve block we have to always consider a lingual nerve block, long buccal nerve block, and the mental nerve block also. Beside of this, we mostly frequently we use a intraoral mandibular nerve block technique, but there are extraoral nerve block technique also. We'll see in brief at the end of my today's session. Classical technique of the mandibular anesthesia. As you know, the indication of it is multiple procedure we can do in for one quadrant at a one injection. A buccal soft tissue anesthesia have we can achieve very nicely. When lingual and soft tissue anesthesia is required with the bone anesthesia, we can use the mandibular nerve block technique. Contraindication in acute infection in the pterygomastoid mandibular space, it will not work goodly on the mentally retarded person. We should avoid this as the as the tongue is anesthetized in this procedure. Advantage of this method is it's a single injection technique which is very useful in the patient having anxiety of the needle prick, right? Disadvantage, a wide area of anesthesia is we can achieve, so the patient may feel a discomfort or the sometimes a lingual lower lip anesthesia after the procedure. Patient they go at the home and they may having a lip bite also, so such a disadvantage are there, but mostly it's advantageous procedure only. As I said earlier, our inferior alveolar nerve, main branch of nerve, is goes from the mandibular foramen medial to the mandibular ramus inside here, and it's run like this, right? So we have to target this area and this area to achieve the good mandibular nerve block or the inferior alveolar nerve block, right? Position of needle during the classical technique, as I said earlier, we have to go from the opposite side of premolar and we have to hit at this point of time just above the occlusal level 5 to 6 millimeter above, and the just posterior to the lingula or the mandibular foramen, right? When we see the from the above, our needle direction it should be like this, or the opposite mouth of the corner or the opposite premolar we should inject like this. So we have to keep these images keep in mind, right? After the inferior alveolar nerve block, which area we should get anesthetized, right? So almost half of the quadrant from the midline to the that last third molar we can able to anesthetize. Then the periosteum, the mucous membrane of the half of the quadrant, the lip and the tongue of the half of the tongue we can able to anesthetize with this method. So it's a very useful method. We should give a wide range of anesthesia with the one injection only. The position of the operator and the patient, mostly we can use standing doctor's method or the sitting on chair method. For the inferior alveolar nerve block, we should on the right side we should sit at the 8 o'clock position and facing the patient, and for the right and for the left inferior alveolar nerve block we should sit at the 10 o'clock position, or we should at the 10 o'clock position, right? What are the landmark of the injection technique? The main landmark is the coronoid notch, then the pterygomandibular raphe and the occlusal plane. So we should, so you have to just keep in mind this point, the midpoint of the pterygomandibular raphe we have to hit, or we should insert from this point. So keep this point in mind. It's a very key point I am telling you, and we have to start from the opposite premolar. So our direction is toward this. We have to hold this ramus in our one hand, and we have to insert from the this end, and we have to always of above 5 to 8 millimeter above the our occlusion plane of the mandibular tooth, right? So these are the important landmark we have to keep in mind. Here also the here also the anterior ramus technique is I have explained as my previous slide. We have to go from the buccally and we have to reach at this anterior ramus and to the medial side of the ascending ramus just below to the mandibular foramen. Here the injection technique is done. So next is a mandibular nerve block with the Gowgate's technique. It's given by Gowgate's in 1973. Advantage over the inferior nerve block is its higher success rates, the lower incidence of positive aspiration, absence of the problem with the accessory sensory innervation to the mandibular teeth. Indication: multiple procedure on the mandibular teeth when the buccal soft tissue anesthesia from the third molar to the midline is required. Like any pathology in this region, we can do it. Then when the lingual soft tissue anesthesia is required, and the when a conventional inferior alveolar nerve block is unsuccessful, then also we can opt for this Gowgate's technique. As I said earlier, that it is if you are not yet tried, believe me, this is a one of the simple and more accurate technique. You should try once. So I am in my this slide I am showing you the point of insertion. So for the Gowgate's mandibular technique, you have to keep this anatomical landmark in your mind. We have to insert from the medio palatal cusp of the second molar, right? So keep this point at in your mind. So we have to insert from this side like this, and we have to hit the mandible. So where we have to hit almost more superior level of the mandibular foramen near to the condylar region, so we can able to block the inferior alveolar nerve in a one injection, right? Contraindication: as I said earlier, infection or the pus in that region will not help to work my anesthesia. In such cases, we should avoid this method. Patient who might bite either their lip and their tongue, such as a young children and a physically mentally handicapped patient, so we should avoid this method. Patient who are unable to open their mouth open, so in that case also it will not work. Advantages: accessory innervation has been blocked, then higher success rate, more than 95% with the experience. Believe me, you should, if you are not tried this Gowgate's technique, and then you should try it once and you will get amazing result. Minimum aspiration, as we inject it at more superior level, so there is a less chances to hit the arteries and vein, and the will get aspiration. So it's a minimum aspiration rate. So few post injection complication like trismus. So we are bypassing the muscle also, so it will reduce the trismus chances also, and provide a successful anesthesia when the bifid and inferior alveolar nerve and the mandibular canal are present. In the anatomical differentiation, if happen in some cases, then also it will work nicely. Disadvantage: lingual and the lower lip anesthesia is uncomfortable for many patients and possibly damage to the certain individuals, so at that time we should avoid this. The time of the onset of the anesthesia is lower, 5 minutes, than with the inferior alveolar nerve. So because of we are injecting at the higher position of the nerve, so it will take more time to anesthetize the our nerve. There is a learning curve with the Gowgate's technique. As we said, it's more technique sensitive method than the classical inferior alveolar nerve technique. So we should master this technique with the practice. Yes, practice you makes you perfect always. And then what are the landmark? For the extraoral landmark, we should always think for the lower border of the tragus and the corner of the mouth, like here, and this tragus we should keep in mind. Then intraorally, mesiopalatal, as I said, mesiopalatal cusp of the maxillary second molar, and the penetration of the soft tissue just distal to the maxillary second molar at the highest established in the preceding step, we should inject, right? So as I said earlier, we have to hit at the more superior level of the inferior alveolar nerve just before entering it inside the mandibular foramen. So here at just below the condyle we have to hit here, so we can able to achieve a good inferior alveolar nerve block technique. I insist to try it once or twice, Then classical inferior alveolar nerve technique. Let's proceed for the Vazirani Akinosi closed mouth technique. This method is given by Dr. Joseph Akinosi in 1977. It's a very useful technique where patient having a trismus or oral submucous fibrosis. In that cases, we not able to use a classical inferior alveolar nerve block technique. In such patient, we can use a Vazirani Akinosi closed mouth nerve block technique. What are the landmarks? The occlusal play for the occluding teeth, then bucco-gingival junction of the maxillary molar teeth, maxillary tuberosity, and the coronoid notch of the mandibular ramus. Indication, as I said earlier, in trismus patient. So we in such cases we have to use it. So in this image, we have to keep in mind we have to use the maxillary teeth gingival border, right? Gingival dental border. So here also, at this point you have to inject, right? So keep this margins of the maxillary teeth gingiva, so, and to the parallel to the this line, right? Here my injection is parallel to the gingival dental margins, and we have to go to the medial to the condyle and the ramus of the mandible, and we have to just slight tilt our needles bevel toward the ramus and hit the bone, and then we have to inject the desired amount of the local anesthesia solution. Advantage over classical inferior alveolar nerve block is, first, the landmark are easily identified and the technique is simple to the master. Second, the three major nerve innervating to mandible may be anesthetized with the one needle insertion. Third, many apprehensive patients feel less threatened psychologically when anesthesia administered by this method. Disadvantage, since the technique rely on a minimum of the bony landmark for its execution, one is likely to be less successful with this method. The depth of the needle insertion is a nebulous factor, and the result is maybe failure. In addition, improper angulation in a superior direction may result in a partial or complete anesthesia to the maxilla. As I said earlier, the angulation for this is very important. If we go more towards superiorly, there is a chances of anesthesia of the maxillary nerve block also. Let's proceed for the lingual nerve anesthesia. As we know, in classical inferior alveolar nerve block technique, when we after the depositing of the 2 ml of the local anesthesia lignocaine solution at the when we hit the mandibular ramus, and we deposit the solution when we take out the needle outside, so indirectly we are um, we are anesthetizing the lingual nerve also. So this is the indirect technique of the giving a lingual nerve block. So in the literature there are three methods are given. One, as I said earlier, by blocking the lingual nerve at the same time of the intraoral inferior anesthesia dental injection. Second, the submucosal infiltration of the just 0.5 ml of the anesthetic a few below and the behind the region of the lower third molar on its lingual aspect. And third one, the infiltration of the LA solution immediately lingual to the lingual gingival of the mucosa to be treated. Here, as I said earlier, at just third molar area region, just 5 below, we have to inject here to give a lingual nerve block separately, and while depositing the nerve block for the inferior alveolar nerve block, we should deposit the solution while withdrawing the needle here level. So at this point also lingual nerve block is anesthetized, or directly give a infiltration method at the lingual surface just 5 millimeter below and the 5 millimeter medial to the soft tissue to the second and the third molar region here. Buccal nerve block technique. As I said earlier, buccal nerve is run from the buccal side of the third molar region, almost 1 centimeter, and it goes to the buccal soft tissue area. So this 0.5 millimeter on buccal side at the occlusal level, we should inject 0.5 ml solution to achieve the buccal nerve block technique. The mental nerve block technique. For the mental nerve block, we have to inject at this mental foramen region. With this technique, we can able to anesthetize this much area of the tooth and the soft tissue area. This is a partial or the just a semi-quadrant nerve anesthesia technique we use for the extra anesthesia technique with the use of the classical inferior nerve block technique also in the case of the infection at that region. As we know, the mental foramen is just between the first and the second premolar region. At here the mental nerve branches are coming out, so we have to deposit at this here only to achieve the mental nerve block. Extraoral technique. Here we are completing the brief information regarding the intraoral method to achieve the classical mandibular nerve block or mandibular anesthesia technique. Sometimes what happens, patient is not comfortable to open the mouth, or the pathology at that region, or the multiple prick we have to avoid. At this time we have to use the extraoral anesthesia technique. So for the aim of this technique is to achieve anesthesia of the nerve after it emerges from the foramen oval at the higher level only. So indication: when it is desirable to anesthetize the entire mandibular nerve and its subdivision with on a needle insertion and a minimum anesthetic solution. When the infection and or trauma makes anesthesia of the nerve difficult to or impossible to identify it intraorally, and the diagnostic or therapeutic purpose also we use this extraoral technique also. For the extraoral technique, the main landmark we have to always palpate these two landmark: articular eminence, and the point of needle insertion is just anterior to the articular eminence here. So between this anterior part of the articular eminence and the coronoid process of the mandible, we have to make a small there is a small space, so we have to inject the needle. So with this at this insertion point, if we go toward backward and downward, then we can, and we deposit the solution here, then we'll achieve the inferior nerve block. If we go anteriorly here, then we can able to achieve a maxillary nerve block. So with the same needle insertion, we can able to achieve the complete mandibular and the maxillary nerve block at the one solution. Here today we are completing the part 2 of my today's local anesthesia method topic. In my next session, I will be covering a maxillary anesthesia method and their different types and the procedure and the landmarks. For the more learning oral surgery lectures, please subscribe, like and share with your friends my oral surgery and beyond YouTube channel. Thank you for listening.